In this lecture, I will be talking on atopy or localized anaphylaxis. Atopy is genetic tendency to produce allergic reaction. It is inherited and mediated by IgE, where levels of total and specific IgE is high. Atopic conditions, allergic bronchial asthma and allergic rhinitis, known as hay fever, are the most frequent manifestations of atopy, followed by atopic dermatitis, known as eczema, and food allergies. Allergic bronchial asthma or atopic asthma. Asthmatic responses lead to degranulation of mast cells, as can be seen here. This is the mast cell, which is tissue cell. They express high affinity Fc epsilon R1 receptors. These are specific for IgE. So in atopic individuals, 90%, nearly 90% of these receptors are occupied by IgE, and this takes place following the first exposure to allergen. Second exposure of the allergen, it leads to cross-linking of the IgE antibodies by the allergen, and this cross-linking sends actually two signals. One signal to the vesicles, and this will lead to degranulation with expression of histamine, platelet activating factor, eosinophil chemoattractant factor, neutrophil chemoattractant factor. The second signal is sent to the wall of the mast cell, where the arachidonic acid, it gives rise through two pathways to leukotrienes and prostaglandins. So the responses or asthmatic responses lead to degranulation of mast cells, and these responses are divided into early and late responses. Early responses occur within minutes and involves histamine, leukotriene, and prostaglandin production, and this will lead to bronchospasm and vasodilatation. Late asthmatic responses occurs hours later and involves secretion of cytokines, for example, interleukin number 5, interleukin number 6, interleukin number 4, interleukin number 5, interleukin number 16, and human necrosis factor alpha, together with eosinophil chemoattractant factor, neutrophil chemoattractant factor, and platelet activating factor. And this will lead to cellular infiltration, blocking of bronchial lumen with mucus. So allergy test, actually these allergy tests are not used to diagnose asthma, but if the patient has allergies that they may be triggering of asthma, so it is used just to diagnose triggers or allergen that precipitate the asthma. And these include skin testing, blood testing. uh, Skin prick test. So just place a drop of allergen on forearm or back and prick it in 15 to 20 minutes. So after that, wheals and flares will occur if the test is positive. Blood test is to measure specific IgE antibodies towards an allergen by means of radioallergosorbent assay test or RAST. Now I will be talking on allergic rhinitis, and this is the most common atopic disorder. It is known as hay fever. Allergic rhinitis results from reaction of airborne allergens with sensitized muscles in the conjunctiva and nasal mucosa. And as can be seen here, these are the mucosa cervis dendritic cells. So these mucosa cervis dendritic cells processed airborne allergens and present them to T helper 2, this as can be seen here, which get activated and produce cytokines. For example, interleukin number 3, interleukin number 5, and interleukin number 4. Interleukin number 4 is responsible for class switch to IgE, where interleukin number 5 is responsible for eosinophil proliferation. And actually, this is the pathophysiology of allergic rhinitis. Classification of allergic rhinitis. Allergic rhinitis classified according to duration into intermittent, where symptoms persist less than 4 days per week or less than 4 consecutive weeks, or persistent allergic rhinitis. Persistent allergic rhinitis as symptoms that are present more than 4 days per week and for more than 4 consecutive weeks, and also classified according to symptoms into mild, when patient has no impaired sleep and is able to perform normal activities, or moderate to severe, when allergic rhinitis interferes with sleep and daily activities. So diagnosis, it is skin prick test. So it is informed just to place a drop of allergen on forearm or back and prick it. So in 15 to 20 minutes, wheals and flares will occur if the test is positive, and blood test to measure levels of specific IgE by radioallergosorbent test or RAST. Treatment: nasal saline irrigation, oral antihistamine, intranasal corticosteroids, combination intranasal corticosteroid antihistamine sprays, leukotriene receptor antagonist, immunotherapy. So immunotherapy to allergic rhinitis, this with gradually increasing doses of allergens to which the patient is allergic, and this is known as hyposensitization. And this is actually in form of repeated subcutaneous injections of allergens that lead to shift of IgE production towards IgE production, or to shift from T helper 2 to T helper 1 with interferon gamma with turning of the IgE responses. And as can be seen here, these are it is in form the therapy, it is in form of monoclonal anti-IgE that it binds to free IgE, not bound IgE to these receptors, or just shift towards IgE that IgE antibodies that bind to allergen, or shift from T helper 2 to T helper 1. So this will lead to actually there is no production of IgE antibodies by T helper 2. Subcutaneous immunotherapy is well established, but however the risk of anaphylaxis has led to the development of other administration routes such as oral, sublingual, or nasal routes. I will be talking now on food allergies. So, as can be seen here, some individuals may be allergic to some foods, and they produce IgE antibodies to these foods, and allergen cross-linking of a specific IgE, as can be seen here. This is muscle in the upper and lower part of the gastrointestinal tract, and this is specific IgE. It will bind to Fc epsilon R1 receptors on the surface of muscle, and so when these allergens or specific or allergens, food allergens, cross-link the IgE or the Fab part of IgE antibodies that bind to Fc epsilon R1 receptors, actually this will lead to a smooth muscle contraction of the GIT and result in vomiting and diarrhea. So increased mucous membrane permeability of the GIT allows allergen to enter the circulation, and this will lead to asthmatic attack or atopic urticaria. When allergen through the blood taken, and also this urticaria, it takes place when allergen through the blood taken to sensitized muscle in the skin. And this leads to wheals and flare, and this reaction actually it is known as Brosnitz-Kusner reaction. So diagnosis of food allergies, it is by skin test, blood test, or oral food challenge. Skin test, it is also skin prick test. It is similar to other atopic disorders, and it is in form of placing a drop of allergen on forearm or back and prick it, and in 15 to 20 minutes wheals and flares will occur if the test is positive. And also blood test to measure a specific IgE by means of radio sorbent test, or rust. In general, immunotherapy to allergic disease, and this immunotherapy is with gradually increasing doses of allergen to which the patient is allergic, and this type of therapy is known as hypo sensitization. So repeated subcutaneous injection of allergens lead to shift towards IgG production, or to a shift from T helper 2 to T helper 1, with turning off the IgE response. So IgE antibodies bind to allergen, as can be seen here, and it will form a complex that removed by phagocytosis. Monoclonal IgE, monoclonal anti-IgE, which is a form of immunotherapy, it binds to free IgE specific antibodies, but not to bound IgE. As can be seen here, this specific IgE now they bind to Fc epsilon R1. So this type of therapy is effective against the free form of a specific IgE. Subcutaneous immunotherapy is well established, but however, the risk of anaphylaxis has led to development of other administration routes, such as the oral, sublingual, or nasal route. So now I will be talking on atopic dermatitis or eczema. Atopic dermatitis, it is T helper 2 mediated disorder, and predisposal or predisposing factors are multiple. For example, epidermal gene mutations, skin barrier dysfunction, and as you may know that skin barrier is an innate immune barrier. So this dysfunction of this barrier may predispose to atopic dermatitis, and in case also of immune dysregulation and microbial imbalance. So these factors can contribute to development of atopic dermatitis. In case of atopic dermatitis, IgE is high, as it is type 1 hyper sensitivity. Some cytokines also are high in atopic dermatitis, for example, interleukin number 4 and interleukin number 13. And as you may know that these antibodies lead to class switch to IgE antibodies. Also, in addition to that, some cytokines, for example, interleukin 17 and interleukin 22, are also high, and this lead to skin barrier dysfunction. Diagnosis of atopic dermatitis by means of patch testing. And actually, in patch testing, tiny amount of allergens are applied to the skin of the back and covered. So 2 days later, the cover is removed and test for the reaction. Thank you very much, Professor Ahmed Bola.